Hi guys, Dr. Gillard here again. Let's do some CVPP, shall we? It is spring 2020, it is week 4, and it is Tuesday. And here we go. So we left off, we didn't start talking about these yet. Let's talk about aneurysms, a very important topic, right? These things can definitely kill you. So in general, it's an abnormal dilation or outpouching of a blood vessel wall. There's like a general outpouching. This is a very focal outpouching. That's called a saccular aneurysm, and we'll get to that. But sometimes the whole artery bulges out, the whole thing, and it's hard to tell the difference. Almost always occurs within the arteries, which are under higher pressure, right? It doesn't usually happen within veins because they're under low pressure. And if you have a connective tissue disease and you have a vein aneurysm, you probably already will be dead from an arterial aneurysm because it has higher pressure. So very rare for them to occur in veins. If it does, it's typically the popliteal vein for whatever reason. They can be congenital. You can be born with these things. Or like berry aneurysms. We'll look at those probably Thursday. Or they can be acquired from an infection or something that eats a hole in the wall of the blood vessel or weakens the blood vessel. The official diagnosis is made when the vessel is measured to be 50% bigger than normal. That's kind of the rule of thumb with this thing. And it may or may not be associated with a dissection, and we'll talk about dissection when the time comes. But just in general, dissection is a split through the tunica media. Right? Did I turn on my tools? Let's see if I can draw. So here's a blood vessel. I mean, we'll cover this. I will actually cover this on Thursday, but just to give you an idea, there's tunica adventitia. There's the tunica media, we'll say. There's the tunica intima. I won't do the other side. Right, so the blood is flowing through here. So if you get a rip, let's turn to red. If you get a rip through the tunica intima, the blood can actually go through the tunica intima, and what usually happens, it gets stopped in the tunica media. So it goes through the tunica intima, gets stopped in tunica media, and it can't rip anymore, but instead it finds it pretty easy to actually rip its way down right through the substance of the tunica media. And that's called a dissecting aneurysm. Those are hard to tell just from ultrasound. You really have to get a CT because fusiform aneurysms harbor or hide these, and you don't even know that. But that's kind of a look into the future. That's what a dissection is, though. So in general, still we're talking about aneurysms means the integrity of the vessel wall has been compromised. So it's either been weakened, as we said, from like an inflammation or an autoimmune disease like Berger's disease where it attacks tunica intima. That can weaken the blood vessel wall. Atherosclerosis is a weakening process. That's an inflammation. Infection is inflammation. Autoimmune disease is inflammation. So inflammation can weaken, cause a structural weakening of the wall. The connective tissue diseases like Marfan's, Louis Dietz, Ehlers-Danlos, those guys, they can also do it, right? Genetic weakness. Or just suffering chronic hypertension for years and years. Chronic hypertension, of course, usually causes atherosclerosis, one of the weakening conditions. So this can weaken. But they're not always from weakening. Sometimes it's from some type of penetrating or ripping type injury to the tunica medias. Like you had a catheter procedure done and they accidentally dug into the tunica intima and damaged the vessel. That can later cause trouble later on down the road. Or maybe a car accident where you hit your chest on the steering wheel and you get a concussion injury to the aorta. That can rip it as well. Right, still in general. So, yeah, the ballooning out can cause sudden death, right? If the ballooning out rips, these, especially we're talking about the aortas here, This is what we're usually talking about. It could be the common iliac. It could be the external iliac, maybe the common femoral, maybe the femoral, deep femoral. Usually it's the aorta is what we're talking about with aneurysms. How come? Good. That's where the pressure is the highest. All right. Yeah, so if you burst one of those high pressure pipes, you're going to bleed so bad the R2A system and sympathetic tiger, they're not going to be able to save you. You're going to go into hypovolemic shock and die from that. So very dangerous. Medical emergency when these things rupture. Laminar blood flow could also, so these aneurysms, they don't usually have a nice flow of blood, and the blood is swirling, and that's conducive to thrombus formation. And so thrombus, just like in the venous system, arterial thrombus can also get so big that a chunk breaks off, and now you got yourself a deadly arterial embolism. And those are no joke, right? They, depending on where it happens, if it happens in your heart or if it happens in your ascending aorta, those things can get up into the noodle, up into your brain and cause a stroke. So they can be very dangerous. What are the risk factors for an aneurysm? Well, people with connective tissue diseases are at risk, as we said. Here's the 4. You got to know these. You probably know them already, but if you don't, you got to memorize these. Marfan Syndrome, Ehlers-Danlos, the vascular type of Ehlers-Danlos. There's 4 or 5 types. There's probably more by now, but there's a lot of different types of Ehlers-Danlos syndrome. It's the vascular type that is dangerous. Louis-Dietz syndrome and neurofibromatosis 1 also genetically weakens the blood vessel wall. We're not going to look at all of these, but let's pick out Marfan syndrome. I don't know if someone's taught you. I think usually you don't know too much about Marfan's, but let's talk about it. This is my benchmark, right? You don't like to talk about things rarer than Marfan syndrome. Population prevalence is 0.01, and it is autosomal dominant gene disorder that causes it. And we'll look at the fibrillin-1 gene here in a second. What exactly is the mutation? But the gene makes a protein called fibrillin-1, which is in all of our pipes. It's in a lot of our pipes, in the tunica media. Remember the organ, or what was that thing? Was it an organ, that thing that you play? Because the tunica media looks like a sandwich, and it can stretch in and stretch out, and it's filled with collagen, right? Well, fibrillin-1 makes up a good part of that collagen, so it's not a good place to have a mutation. I'm still trying to think of the name of that, like a squeeze box thing, or I can't remember. I don't think anybody plays those anymore. But anyway, targets connective tissue of the body and makes it weak, and that's not a good thing. You can have all kinds of problems with the eyes and with the heart and with the blood vessels and etc. So these people, of course, have very long and flexible fingers and toes. The syndrome is given the name arachnodactylia when this person has arachnodactyly. Because of the long fingers. That's one characteristic trait of Marfan syndrome. They have trouble with heart valves. So the heart valves normally have to close very strongly to resist systole, right? The mitral valve has to resist systole. Well, sometimes that fibrillin-1 is in the mitral valve, and when systole occurs, it kind of caves it in, and you squirt blood up into your left atria. Which is not good, right? That's called a regurgitation. We'll look at that officially here in a minute. But those affected tend to have defective or stretchy heart valves that don't seal like they're supposed to. And this results in 2 classic conditions. And they're both kind of sagging conditions where the valves can't stand the pressure and they cave in and leak. So that's called prolapse, when the valves sag inward because of pressure. So the 2 valves that are under the highest pressure are the ones that we care about, the aortic valve, mitral valve. Tricuspid could also have a regurgitation, so could the pulmonic, but those really aren't as clinically as dangerous as these aortic and mitral valve because they're under really high pressure. Okay, so regurgitant is called regurgitant valvular disease, both aortic or pulmonic regurgitation. So if you're having leakage into the back chambers, you're not, let's use the mitral valve, for example. If you have systole and you're trying to eject all the blood out into the ascending aorta, but some of it is backwashing back into the left atria, you're not going to get a great ejection fraction. And yeah, so you have decreased cardiac output with these conditions. Okay, especially mitral valve regurgitation. The heart has to pump harder to recover. The body perfusion drops, so the heart has to pump harder. You wreck your heart because of this. Eventually leads to heart failure, left-sided heart failure. It also is a beaver dam, right? Because now we got extra blood in the left atria that can't get out. And so here comes the next cycle. The lungs are trying to fill the left atria up, and they can't fill it up like they used to. And so you got yourself a beaver dam, and that blood can back up and back up. And as it does, it causes pulmonary congestion and hypertension, which we've talked quite a bit about already. And eventually you get yourself, do you get cor pulmonale from this? What's cor pulmonale? Well, it's right heart failure. You can get right heart. No, this is not cor pulmonale. Cor pulmonale has to be coming. The cause of the beaver dam has to be lung related, like COPD. So you wouldn't call this situation where they have mitral valve prolapse does not cause cor pulmonale, but it sure can cause right heart failure. All right, here's a little cartoon. So here is systole has occurred, and this blood is flying out of this is the left ventricle, and this is a cartoon of the left atrium, which is really more in the back, right? Left atrium is actually the most posterior structure of the heart. That's what the heart sits on, but that's how they draw these cartoons so we can understand them. So the valve is supposed to be closing, but the pressure is too much, and it's filling and leaking with blood. So now here's the pulmonary veins coming in, trying to fill this thing up, and they can't. It's got, during diastole, it's already got too much blood in it, so you got yourself a beaver dam. Everybody see how that works? How come this is? Because the fibrillin 1 gene is mutated, and this tissue is too stretchy, doesn't work good. Okay. Also affects many other different tissues and bodies. These are tissues in the body as well. We'll look at some of them. They tend to be really tall and slender. Basketball players can have this condition. They have to make sure their pipes are okay before they're cleared to play something like that. Two most common clinical sequelae of Marfan syndrome. One we just talked about, aortic valve prolapse. So mitral valve prolapse as well, but aortic is more dangerous. Also can cause a beaver dam because the blood still, now you can't, with mitral valve prolapse, you can't fill the atria, left atria is already flooded. But with aortic valve prolapse, you can't fill the left ventricle because blood has backwashed into that. They both are beaver dams. Number one problem, though, is not aortic valve prolapse. It's actually something called ectopia lentis. Ectopia lentis. And that is a dislocation of the lens of the eye, one or both. And remember the lens we all have, we're looking through lenses right now. Can you see the lens of your eye? You can't see it normally because it is in perfect position and it's filtering light perfectly. Okay, and this is not the cornea of the eye either. It's the lens behind it, which thickens when something comes close to you. It has to thicken so you can read close up, and it thins as you go away. We'll look at this out. We'll look at it right now. So here's the lens. There's the cornea out here. Here's the lens, and turns out that these suspensory ligaments have a high degree of fibrillin 1 protein in their collagen. And so number one problem for someone with Marfan's is you get a degeneration. This might be overdoing it a bit. They probably stretch and get lax so the lens gets out of position. I guess they could snap like this, but I think they're just trying to prove a point here. Let's take a look at one. Well, that's freaky, isn't it? You've never seen the lens before. But that's the lens. It probably has snapped in this one. But yeah. So that's a Marfan's patient, and he's got ectopia lentis. Because the lens is out of place, now it's reflecting light, and we can see it. All right, diastole, so aortic valve regurgitation. Didn't really talk about that one, but so systole has occurred and shot blood out. There's the ascending aorta there. And now that recoil, remember we talked about the recoil? How the blood vessel during systole, I'm going to exaggerate this, but it stretches way out like this. But then during diastole, because, accordion, that was the word I'm looking for, accordion. That accordion effect, because of that tunica media and all that elastic tissue, this thing squeezes back together, and any blood that's in the area gets shot this way, and it gets shot back this way, and that's what, I guess I should switch to blue here, it shoots back this way, and it pops these little parachute, like, these are like a drag racing car, these things, and they're, when the blood, you can see them from this side over here, the blood flows backwards and pops these things right open. But if they're defective, then they leak. And it's leaking blood. We'll do blue blood. It's leaking extra blood into here. Not like a ton of it, but when it's then diastole comes, then you can't fill this like you're supposed to because there's already blood in there, so it causes a beaver dam. Causes a beaver dam right there. So these people are really, really flexible as well. So this is a common test. People with other connective, there's mixed connective tissue disorders where they got a touch of this. I know some students who've been able to do this. Some really tall students. And they probably do have a touch of connective tissue disease. If you can do that, you shouldn't be able to do that. But yeah, so the fibrin 1 protein is in all of these types of ligaments and makes people really, really stretchy. Okay, what's the cause? I kind of told you the cause, but let's make it official now. So it's caused by a missense mutation of the fibrillin 1 gene. What in the world, a missense? Did somebody go over that with you? If not, we'll go over it right now. You probably learned that in undergraduate, I assume. You must have had a genetics class. But yeah, so missense mutation with fibrillin 1 gene, therefore your fibrillin 1 protein, after going through the central dogma, is defective. And the fibrillin 1 protein is in the tunica media of some really important connective tissue, including the lens, the suspensory ligaments, which attach to the lens of the eye, your tunica media, and your blood vessels, and ligaments, and yeah, there's a whole bunch of it stuff. So recall that a missense mutation is a single DNA nucleotide change in the template strand. Just one little flip of an adenine and thymine are flipped. We'll see it in a second. I think we'll see in a second. I got it written down. But this creates a codon error, right? Every three nucleotides makes up a codon. So you get a codon error, and it inserts the wrong protein as you go through the process of the central dogma. So RNA polymerase, so we'll start at transcription. It's the first part of the central dogma. I mean, arguably, you could say DNA replication through DNA polymerase is the first part of the central dogma. And then comes making proteins through transcription translation. But RNA polymerase transcribes, makes a messenger RNA that's screwed up, right? And then that goes to a ribosome and gets read, and that's screwed up, right? Because of that. And I mean, it's not horribly screwed up. It's just got one darn base pair that's off, but that's enough to insert I believe it's a uracil. Well, let's see. We'll see what it is. So the defective fibrillin protein is inserted into the collagen throughout the body, and it creates a weakness. So in the tunica media, that's not a good place to have a weakness, right? Because you're prone to have aneurysms, and that's what we're talking about. Aneurysms can burst, and they can cause death. You can go into hypovolemic shock. All right, so just throw a couple slides in here. You got your boards coming. You're going to need to know this stuff. So that's a nucleotide. Is this a RNA or a DNA nucleotide? It's a deoxy. Remember, RNAs have a hydroxyl group here, and DNA doesn't. That's why it's called deoxy. And on the ribose, that's a ribose sugar, deoxyribonucleic acid. But this is a nucleotide. What kind of nucleotide is it? Remember, nucleotides are named by one of 4 bases that are attached to them. That happens to be a thymine, so this is a thymine nucleotide. Remember the deal with that? And the base pairs, that's an easy question, even for me. Expect you to know this stuff. They should probably know this in junior high. Adenine, thymine, cytosine, and guanine, those are the pairs that pair up. But remember, in RNA, there's no thymine. Instead, there's a uracil which replaces thymine, but the uracil still pairs up with adenine. Remember this stuff? Here's a DNA molecule. Remember, the DNA is double-stranded when an RNA is single-stranded. Although the RNA usually folds, right? Remember the RNA molecule? It folds back on itself, and it can form these bonds. So you can't really say it's double-stranded, but it likes to be in a conformation that's double-stranded in an RNA, even though it is single-stranded, right? Remember that stuff? Okay, but that's how they hook up. So they're hooked up by hydrogen bonds, and they always pair. Adenine pairs with thymine. That has to be memorized for me and for boards, for everybody. I remember athletic trainers go together. And then GC go together. Guanine, cytosine go together. Those little stronger bond there. And there's the sugar and phosphate. And yeah, so that's just part of a DNA strand right there. And remember to read this, remember some of these, maybe these guys are part of a little small gene right here. So some of them are coding regions on a DNA, and they have the blueprint to build stuff like fibrillin 1 protein, like the lens of your eye, like a valve of your heart. That's where all this information is. So you have to break these hydrogen bonds and read this. RNA polymerase has to read one of these. One's the template strand. That has to be read. Right, so here's the central dogma, and here's just a kind of cartoon of it. We're inside the nucleus of the cell, right? Here's the nuclear membrane. So RNA polymerase comes in, and the DNA the double helix is split open, so the RNA machinery can actually read the one strand of the DNA. The strand that it reads is called the template strand, and the template, the RNA polymerase is going to read it and create with nucleotides, but with RNA nucleotides, it's going to create an exact copy of the template strand. Only it's single-stranded. It's not going to be double-stranded. And then the template strand, remember that has to be processed. You have exons, which are good, and introns, which are junk. You have to cut out the introns. And then you have yourself an mRNA that is ready to be read. It's a blueprint of, in this case, this is the instructions how to make the fibrillin 1 protein. And that swims out of the nucleus. There's these little pores that it can go right through. And it finds a ribosome. A ribosome is what actually makes protein. And so it goes into the ribosome, and the ribosome starts putting amino acids. Every 3 of these nucleic acids is a codon. And every 3 of those tells the ribosome which amino acid to put in. And so we got ourselves a fibrillin 1 protein here. So if you're shaky on this, oh my God, there's so many great videos, YouTube videos on this. I sure wish I had those videos when I went to school. But yeah, you can go there and get kind of caught up on that if you don't understand what I'm talking. Hopefully you understand what I'm talking about. But here's the missense mutation in Marfan's. So here's a DNA molecule. It's still, there's the 2 strands of it. Remember I said every three represent a codon. And so right here's the problem. The T and the A are flipped. So this is the non-coding strand. This is the coding strand, or coding template here. And this should be a thiamine, and the adenine should be up here. But because like this is normal. So that creates a messenger RNA that has GAG as its codon. When the ribosome reads GAG, it knows to insert glutamic acid or glutamine. The same thing, just different form. So glutamine is inserted, but because of this flip, A binds with uracil, and we get a GUG codon in the Marfan's mRNA, and the ribosome brings in valine for that. And that one little valine molecule, it doesn't make the tissue completely screwed up, but it makes it fold in a way that's not conducive to strength. And it basically makes it weak. It still works, but it's just not very strong anymore because of this valine. And that's the only, in the entire fibrillin 1 protein, that's the only thing that's screwed up, is just that valine. Okay, there is the genetic code right there. And you guys have had classes in this, right? And this is what the ribosome looks at. Well, the ribosome doesn't look at this, but you can imagine the ribosome looks at this and says, okay, I forgot. We have 3 RNA nucleic acids. They're guanine, adenine, and guanine. What amino acid do I have to bring in? And it calls in a transfer RNA, right? I have to call in, which transfer RNA should I call in? Oh, glutamic acid or glutamine. Okay, that's how that works. And then there's stop codons, and I'm not going to go that crazy. There's just incredible videos out there. But here's inside a ribosome. These are the transfer RNAs. These are the codons. This is the template, or this is the mRNA strand right here. And it right in this part, these 3 compartments, this compartment is able to read the codon, and it reads a GUG, and okay, A matches with U, so it brings in a valine in this case. So that's no good, right? So that's the fibrillin 1 mutation. Everybody good with that? Simple questions, right? Nobody should miss those. All right, some other risk factors. So we also have type 4 of Ehlers-Danlos syndrome, which is the vascular type. These people also have a missense mutation, exactly what we just talked about. Only theirs codes for the COL3A1 gene and the COL3A1 collagen protein. And basically that is a type 3 type of collagen that is defective in people with Ehlers-Danlos syndrome. They have the same trouble, though. The blood vessel walls are weak. They're flexible like that. They're not usually tall like Marfan's, and they don't have the eye problem, to my understanding. But yeah, so it's the same type of story with Ehlers-Danlos, but it's the COL3A1 gene that's mutated. Okay, Louis-Dietz is another one. It is a connective tissue disorder which involves a mutation of the gene that makes the transforming growth factor beta gene, and that's another important protein. And of course, the TGF-beta gene makes the TGF-beta protein, which is a collagen. I think it's type 7 or something like that. But it makes another important collagen for the blood vessel wall. And yeah, so they're at risk for aneurysm, people with this type of gene mutation. They also have horrible scoliosis, clubfoot, striae distentia, really bad striae, stretch marks, pectus excavatum. So they have some other things that Marfan's people usually don't have, or Ehlers-Danlos patients don't have either. Tertiary syphilis is mentioned in Robbins, but not Rubens. I thought I'd throw it in there. That can cause some mutations, or that can just cause flat-out damage to the blood vessel, that it gets kind of burrows into blood vessels. We're not going to see that much in this country, though. There's one called familiar thoracic aorta aneurysm syndrome. It can be passed down through families. It's another mutation in transforming growth factor beta mutation. Not so excited about those. I am excited about Marfan's, though, and Louis-Dietz and Ehlers-Danlos. How about some other risk factors? Trauma. I said if you get in a car accident, you hit your chest on the steering wheel, you can get a concussion injury. Or fibromuscular dysplasia, we talked about that a bit, how it thickens the tunica media and it weakens it as well. So those patients are at risk, or those people who are affected, they're at risk as well. People who've had vasculitis, it's usually from a bacteria, but it can be an autoimmune disease. I think there's like 40 different types of vasculitis. We talked about one actually, didn't we, in lab? That's going to be on your lab test next week. What one was that? Giant cell temporal arteritis is a common vasculitis, right? It causes amaurosa fuga, the shade-drawn blindness. That's what amaurosa fuga means. And it's the temporal artery is inflamed, painful to the touch, and that's the least of our worries. If the temporal artery is inflamed, so is the optic, and people go blind from that condition. That's a vasculitis. It can affect the vertebral arteries too, so you can get aneurysms from that giant cell temporal arteritis as well. If it is caused by a bacteria, then it's called a mycotic aneurysm. We'll talk about this specifically here in a second. But people think that's one of my answer choices is always fungus, because mycotic, you think of a fungus. It has nothing to do. It's always bacteria, almost always bacteria. Why they named it like that, I have no idea. We'll be talking about these little buggers, these berry aneurysms, probably on Thursday. Everybody loves berry aneurysms, so we got to know all about those. This question's got quite a few stars collected. I think I ask this every quarter. So, because you would think everything we've been talking about is weakening the blood vessel wall and increasing the risk for aneurysm. Well, here's a condition that actually saves you, decreases the chance of you having an aneurysm, and lo and behold, it's diabetes from all things. And so the mechanism of that is, especially people who the diabetes is not well controlled, they have frequent bouts of hyperglycemia, and all that sugar gets into the tunica media. It can get into all the tunics really, but especially the tunica media where all that collagen is, and it starts to, it's like little welders get in there. The sugar welds together the collagen strands, without any enzyme. It's non-enzymatic glycation occurs. And you weld those together and you get a very stiff and start to get a very thick aorta or whatever vessel's been affected by that. So it's the opposite. That thing is going to be, it's welded together. There's no way that thing is going to rip. But there are going to be some problems with that. Here's everything I said. It binds together the collagen, makes it really thick. That binding is called non-enzymatic glycation. Sometimes it's just called glycation. Sometimes it's called glycation-induced cross-linking. But it protects from aneurysm, which is awesome. But you're not out of the woods, because of course the sequelae of especially not well-controlled diabetes, all that cross-linking is going to start to make the tunica media way too big, and it's going to start to narrow the lumen because of the thick tunica media, right? And then if this is a widespread condition, then the heart's going to have to push harder to get the blood through that little hole. And that causes hypertension, and the hypertension can cause atherosclerosis, right? And the atherosclerosis can cause more narrowing. The diabetes causes more narrowing. That causes worse hypertension. It wrecks the heart, and you get that vicious circle. The high sugar levels also are notorious for wrecking your eyes, right? The retinal arteries, and can damage the arteries of the eye, so diabetics can go blind if it's not well controlled. So back to mycotic aneurysm. Again, it's an infectious, aka is infectious or infective aneurysm. Probably a much better term, because mycotic again means a fungus. And these bugs, they invade the blood vessel wall. And so then they spark a inflammation. When bugs invade, the body sees them and causes an inflammation. Staph aureus is notorious for doing this. You go to have a dental procedure and it happens. You get bugs in your bloodstream and some stick to vessel wall, and your body, they dig in, the body spots them. Now you got yourself a wicked inflammation and damaging inflammation. So it weakens the blood vessel. And if the blood vessel can't hold pressure very well, that area is going to kind of bulge out. And now you got yourself an aneurysm of one kind or other. And it could be a true aneurysm or a false aneurysm or dissecting. Those are the three flavors of aneurysm. All right. Where does the infective agent come from? Dental procedures, I said. Could be a cut and wound on your leg, a blister on the back of your heel. So the tissue, the bug gets into the bloodstream and causes trouble. TB's notorious, not in this country, but for getting in and causing these things as well. What's the sequelae of aneurysm? Well, they might burst, right? That's the sequelae, the dangerous one. The thing could burst because of the high pressure, and you're going to have, if you're bleeding, you're going to have hypovolemia and go into hypovolemic shock and die from that. In addition, let's say it doesn't burst. What else can it do? It can, the infection, especially if it's in the heart, around the valves, it can cause a big bug ball. And the bugs, this ball of bugs, is literally a ball of bugs, can get the size of a marble. And that bug ball can break loose. And now you got yourself a bomb going downstream through the heart. And that's called a septic embolism. And that's super dangerous when it starts in the heart. Right? Because remember, it can go up through the carotid artery, common carotid artery, and get up into the noodle that way, or the brachiocephalic trunk, which leads to the right common carotid. It can get up into the brain. So it can go anywhere. How could it cause a myocardial infarction? We'll talk about that more when we get to the heart. But let's say here's the left ventricle. And here is the ascending aorta. So blood's coming out of there. There's these coronary sinuses. Or what are they called? There's sinus of Valsalva. There's another word for it. But there's three sinuses here where the ostium for the coronary arteries live. Right? So we got a left coronary artery right here. We got a right coronary artery here. Okay, so now you got yourself a bug ball, let's say on the tricuspid or on the bicuspid valve, or the mitral valve, right? You never call it the tricuspid, never call it the bicuspid, always call it the mitral, we'll see. But a piece of this breaks loose, and it's like Russian roulette. Who knows where it'll go? And it goes right in here. Gets stuck. And the LAD, left anterior descending, that's a widowmaker. It kills you. Right? We'll get into the heart big time. But that's how it can cause a heart attack. That can cause a massive heart attack because it's a beaver dam, and anything downstream, coronary arteries are supplying all the myocardia. Right? So that's going to die, and so will you, because if one gets stuck up here, that's worse than a widowmaker if it gets stuck. They usually don't get stuck right here in the left, the start, because these are too big, but as they start to narrow and branch is where they usually get stuck. All right. But maybe it makes it all the way around the aortic arch and goes down and gets stuck in the renal artery. Maybe it causes high blood pressure, turns on the R2A system. Maybe it goes in the splenic artery, and there goes your spleen. You get a spleen infarct. Maybe it goes in the, I got splenic twice. You get the idea. Who knows where it goes? It could go anywhere. What are the favorite targets of these mycotic aneurysms? It loves the abdominal aorta, the thoracic aorta. It loves the renal arteries, so it's not uncommon for this to be the cause of the R2A system. If it gets stuck in the renal artery, and you get a beaver dam and your kidney doesn't get proper blood flow, there goes the R2A system alert, and renin's released, and angiotensin II, and the whole 9 yards goes. They like to be up in the circle of Willis, some of the intracranial arteries. And we'll talk a lot about that circle of Willis. Where can the bugs stick? They also like heart valves. One of their favorite places, if you've had rheumatic fever, the bug that goes with that loves the heart valves, and it damages the heart valves, not to the point where you're having heart dysfunction, but the infection and inflammation scars it up, and the flow of blood is not smooth over those scars, and bugs like to catch. It gives the bugs something to grab onto. The slippery 3 aren't secreted in that region very well. And so they stick in the valves there. Or if you've had an artificial aortic valve placed, they can stick there as well. Or old catheter procedures that nicked the wall, it can happen there as well. Okay, let's look at arteriogram here. So we have contrast in the arteries, and we're taking pictures as going through. What is that? Well, it takes some water. Tell me what that is. Well, what's the view, first of all? That's a axial view, right? There's a cut right through the vertebral body. You can see the ribs coming in. And there's a normal aorta. What do you think of this one? Yeah, that's not good, right? So there's a bug, an aneurysm or a bug ball has started here, and it's actually ate itself in to the blood vessel wall, and it's really happened slowly. So when things happen slow, your body can really accommodate it and grow to amazing size. We'll look at pericarditis. The pericardium normally doesn't stretch, but if it happens slowly, it can stretch to massive amounts. But yeah, that turned out to be a mycotic aneurysm. Eroded the anterior vertebrae here a little bit. How about some risk factors for aneurysm development? These are pretty easy. We talked about atherosclerosis weakens the blood vessel wall. It's an inflammatory process. Hypertension sparks atherosclerosis. Plus, hypertension puts more pressure on the walls of the aortas. So if you have a weak spot, it's going to start to bulge out. Bacterial infection, we just talked about it, especially with rheumatic fever. Vasculitis, that's just an infection of the blood vessel wall. There's different types of those, but that can weaken. And then the connective tissue diseases that we've all talked about. That's a nice little slide to make questions from. What do you do for treatment? Well, it depends how big it is. You have to monitor it really close. Do you have any symptoms of these aneurysms? 0 symptoms. You have no clue that they're there. Chiropractors pick these up on lateral lumbar films. You can, if the patient usually has Munkberg's and atherosclerosis, you can pick up these aneurysms because of the Munkberg's will light them up. But once it gets over, like for the descending aortic aneurysm, which is common, once they get over about 5 centimeters, you're going to have surgery. It's too risky. That thing can pop at any moment. If you have Marfan's disease, they're very aggressive. Anything over 3 centimeters, 3 or more centimeters, they'll do it. So, and treatment, surgery, you got to cut out the bad piece and put on that dark-on graft, just like we talked about before. And it's fairly good surgery. There's still a 2%, 2 out of 100 will die. Usually the older people whose heart can't tolerate the operation. But it's not that they can't fix it. Usually the heart, or they have some other complication like embolisms after the surgery occurs. If they're borderline, if they're not big enough, you have to manage them and watch them with CT or ultrasound. And while you're watching them, you should have them reduce the risk, right? Stop smoking, stop things that elevate blood pressure, control the cholesterol so it doesn't build up. Beta blockers are commonly used, which decrease sympathetic tone. If you back off the sympathetic tiger, the nitric oxide is going to expand or vasodilate a little bit. So, all right, so there are 3 classifications. Let's get a little deeper into the 3 types of aneurysms. So there's true aneurysms, false aneurysms, and dissecting aneurysms. And so here's a review of where we're going, but let's just use these and tell you right now. So saccular aneurysms and these fusiform aneurysms are called true aneurysms. These are the ones we've kind of been talking about. True aneurysm means that the wall, the vessel wall is not ripped, but it's weakened. And it's weakened to the point where it'll bulge out because of the pressure of the blood inside of it. Sometimes it's a very focal outpouching. This is, I mean, like this, or even like this. They look like little berries hanging off. That's where berry aneurysm came from. Or maybe it's just a general outpouching of the entire blood vessel. It's kind of hard to see. So those are the true, real aneurysms. The false aneurysms, I mean, from ultrasound, they can look exactly the same. But on CT, you can actually see a false aneurysm has rip through the tunica intima, through the tunica media, maybe all the way through the adventitia. Maybe the only thing, when they take a CT, maybe the only thing kind of keeping you alive is that connective tissue that covers all blood vessels. And that's emergency surgery if you have something like you could pop and die at any second with that. Right? But false aneurysm means that the tunica media, or at least one of the tunics, at least the tunica intima, is ripped. Sometimes the rip is in between. This is a dissecting aneurysm. And we should do a little drawing here because there's only two ways this can happen. It starts out as a false aneurysm. Remember, false aneurysms have a rip in at least the tunica media. And then the blood gets in, as we talked about, and it gets stuck. Can't get all the way through the tunica media, but it can rip its way up and down. Usually goes down with gravity. That's a dissection. Okay, but there's a rip. Another way that can happen is, remember the vasovassorum? Remember those little blood vessels? You can get an aneurysm on the vasovassorum, and that can rupture, and it can start to split the tunica media apart. And so it is possible to have a dissection. I've actually asked this question before. It's possible to have a dissecting aneurysm without any damage to the tunica intima. Oh, I guess there's the tear they put right there. So it doesn't always happen. If it's a vasovassorum aneurysm that pops, that can also cause a dissection. In fact, that's fairly common for the vertebral arteries. All right, so that's where we're going. And I'm just going to kind of expand on that. So true aneurysms, again, it's a ballooning out of a weakened vessel wall, or the heart. You can have it as well. The key is there's no tear, there's no defect within the heart. It's just a weakening of the wall. And there's no dissection either in these things. So in other words, the tunicas have become weak and they've ballooned out. Right? So there's two forms, as we said, a saccular and a fusiform. Saccular is very easy to identify. Fusiform is sometimes tricky to see. I think we've actually looked at some of those before. But a saccular, okay, let's look at that. It's a true aneurysm. It's an outpouching, but the key word is focal. Focal. It's a focal outpouching. What else uses the word focal? You don't know this yet, but when you start reading radiology reports, focal is a disc herniation. A focal kind of protrusion of the posterior or any part of the annulus is called a disc herniation. Not to be confused with a disc bulge, which I'll show you in a second. So I guess I'll show you right now. So here's a cartoon. This is a bird's eye view, or really an axial view of a cut right through the disc. So we can see the neuroforamen would be here, superior articular process from below, inferior articular process, lamina, spinous, all of L4 property. This is L5 property here. This is the facet joint or zygapophyseal joint. Okay, here's the nucleus, annulus fibrosus. We look at the back of this to see if anything's sticking out because we got nerve roots here. We got a traversing nerve root right here. That's the L5 traversing root. There's the exiting L4 root. Anybody crushing those? No, that looks beautiful. Right? Now here's a cartoon of the same thing. This is a disc herniation. It's actually a contained, the blue is posterior longitudinal ligament. It hasn't ripped through that. But this is a contained, but the key here is there's a focal outpouching of the annulus fibrosus in the paracentral zone here. So that is the same thing as a saccular aneurysm. Here's an old client of mine. With permission, by the way. So there's a protrusion, right? Or disc herniation. And that's just like that's a bad one too, right? Looks like a sac hanging off. So saccular aneurysm looks like a sac. Those things are breeding ground for thrombus formation. Can you imagine the blood flow in those things? So very, very dangerous for a high chance for embolization. So fusiform annulus is like a disc bulge. So, and this is an easy one, but sometimes they're not so easy to see. But it's a general outpouching of the entire region of the aorta. So this is the most common type, and I do like questions when it says most common. It's the most common type of aneurysm, true aneurysm. And there's no rupture. The wall is intact. And this is like a bulging disc, not a herniated disc. Here is a disc bulge where the entire disc is bulging out because it's weak. These things really don't. They could be hiding an annular tear. You can't see an MRI. But about 80% of people over 40 have these. So they usually don't mean a lot. But again, they can hide an annular tear within there. So don't blow those off, right? Sometimes you can have a rip inside here into the sinovertebral nerves. Patient can have horrible, debilitating pain. Sometimes you need to take the disc out, right? Here's a fairly normal-looking view. There's a nucleus pulposus, annulus fibrosus. Yeah, everything looks good. That's probably looks like about L4, maybe L3. Let's say it's L4. There's the L4 exiting root. There's the motor and sensory roots of the L5 root going below, still in the thecal sac. We look back here. Everything looks good. There's the neural foramen here and here. Everything looks good. How about this one? Yeah, it's a bulge. Where's the neural foramen? Intervertebral foramen, or the disc is generally bulging out. That's the same thing as a fusiform aneurysm. You get a general bulging. And it's typically a very long segment that's affected compared to a saccular. In fact, some people, the entire abdominal aorta may be bulged out, and it's really hard to see it. They can reach up to 20 centimeters in diameter. They can get really big if it happens slowly. Sometimes the entire aortic arch can be bulged out. Sometimes the ascending aorta can be bulged out. It can happen anywhere. They can be really big. All right, false aneurysm. So this is also known as a pseudoaneurysm. The vessel wall has ripped itself through, right? So that's a false aneurysm, typically caused by trauma, maybe a catheter procedure. They were doing some type of, maybe taking an IVC field. No, that would be in the vein side. Maybe the balloon angioplasty, where they're trying to put a balloon in your coronary arteries and smash the plaque out to give you your heart some better oxygenation, and maybe they injure a blood vessel doing that. Car crash, blunt trauma, chest hits the steering wheel, causes a concussion and can rip the aorta. Fractured rib can stab a vessel, stab the thoracic aorta. Infection we talked about, a mycotic aneurysm, a bug can eat a hole right through the wall, and now you got yourself a false aneurysm. These things are really dangerous, prone to rupture. They're emergency surgery if you see one of these things. And also prone to future infection. If they do heal, the laminar blood flow is all screwed up there, so the bugs can stick to that injured area. Okay, laminar blood will escape through the tear and go into the tunics. So sometimes the only thing preventing the hemorrhage is the connective tissue on the outside. We already talked about that. And sometimes, we talked about this too, you can get a dissecting aneurysm, often starts from a false aneurysm. A rip and tear through the tunica intima, maybe that rip and tear stops. It can't get through the adventitia, and instead it turns and rips down through the tunica media. Okay, so false aneurysm can give rise to a dissecting aneurysm quite easily. Now, these are the ones that are palpable too. So if you're doing a routine examination, if you're going to work at a medical clinic, like a hybrid medical chiropractic physical therapy acupuncture clinic, which is the best way to treat back pain, right? Multidisciplinary care. It's about the only type of research that shows the best way to treat back pain is multidisciplinary. But you will be examining the abdominal aorta. You should always try to palpate that thing. Same with a VA clinic. We know docs who work there. That's part, you have to be able to do that. And they've found abdominal aneurysms that way. But these are the ones that you can feel. And these guys will be pulsing really, even through diastole sometimes. So if you ever feel one of these things, order an ultrasound. It's got about a 97% sensitivity. Snout, rule it out. It's good for ruling out. And yep, that's how you do it. We'll get to that lab. Actually, you should do it up a little bit higher. It's a little low. All right, we're getting awful close to the carotid artery. It should be done up here. We'll get to that. All right, I think I'm going to stop right there, and we will pick up on Thursday, and we'll really get into these dissecting aneurysms because now it's my favorite area. Boards like this stuff. We got to learn about the DeBakey system and the Stanford system of rating and describing the different types of dissecting aneurysms. All right, see you in the next video.